subjects we're going to talk about today are adverse effects of injectables and how to prevent some of these adverse effects. It's not going to be a totally comprehensive discussion of adverse effects from injectables and the risks involved in injectables. We can't discuss every side effect that possibly can happen. It would be hours in length, so we can't do that. The second subject is going to be on how to treat horizontal necklines and the latest techniques in treating those necklines. And Dr. Cox will give us some insights on how she does it. And the third area is what's called the RHA family of fillers, which are relatively recently approved in the United States for facial augmentation. I'm Dr. Joel Kopelman. I'm in practice in Manhattan and in northern New Jersey, and I do primarily cosmetic facial plastic surgery. And I'm interviewing today Dr. Susan Ellen Cox, who is a world expert on injectables. Dr. Cox is a authority on injectables and other dermatologic treatments, and she's done numerous studies for industry as well as for the public, for the scientific community, and she's a real authority on injectables. And I'm pleased and honored to have her as a guest, and I believe she's going to give us a lot of insight into all the subjects that I've outlined previously. So to begin with, Dr. Cox, welcome. And I have a lot of questions. Specifically, I know you were co-author on an important paper endorsed by the American Society of Dermatologic Surgery a couple of years ago on the prevention and treatment of adverse events from injectable fillers. And I would like to kind of cone in on a few areas that I think are problematic in terms of injections. And that is specific. One area in particular is around the nose. I know that there are many people who believe that you could do a non-surgical rhinoplasty by augmenting the dorsum of the nose. And I see that area as an area of potential serious complications. I wonder if you can comment on that.
Sure. Well, the paper that you're referencing is called Evidence-Based Guidelines of Care, and it was in Dermatologic Surgery, the journal, 2021, February, pages 214 to 226. And it's very comprehensive because basically it's looking at looking at papers that have high evidence level. So we weren't just looking at the one-offs of like case reports, we were looking at really large studies. And as you know, it's hard to find large studies or larger studies with regard to complications because they are in fact luckily so rare typically. But the one that you're mentioning, injecting the nose, Katie Belsley did a beautiful paper with, I believe it was Derek Jones, when she was doing her Future Leader Network through the ASDS. And she looked at articles which showed the highest risk of blindness, like what locations get injected on the face where you have the highest risk of blindness. And lo and behold, the area that you just mentioned, the nose, was the #1 area. And you know why? It's because of the vascular anatomy. You know, the dorsal nasal artery that has an anastomosis behind the orbit, which can produce a retroorbital occlusion and then blindness. So the nose is an extremely high risk area, as is the glabellar area, the forehead, the temples, and somewhat less the periocular region. And it's all just based on where those blood vessels live and what they eventually feed into. I personally don't inject the nose. I just like to sleep at night. So I do. And so I just, that is the one area on the face that I don't inject. Now, maybe I'm foolish because I had a gentleman come in just last week who has coupe de sable, which is a morphia, an area of localized scleroderma, and it was right, it's right in the central forehead. And a couple of years ago, I injected him, and I kind of obviously consent very thoroughly when I'm injecting a high risk area. I do consent for blindness, and I tell them that I don't have Doppler to find the vessels underneath. Maybe I should. I actually even offered that up to him. He was an ER physician. He was like, no. I knew to inject on the bone there, and very slowly, very small volumes, keeping my eye always on the skin, having hyaluronidase right next to me should I need it. So yes, I do inject some high risk areas, but the nose is one of those areas that I just think that it really, it's not worth the risk benefit ratio. I do have my ex-husband who's a mile down the block, who's a facial plastic surgeon, and he does rhinoplasties all day long. That's his favorite operation to do. And he's dissected the nose throughout his residency, and he's been in practice as long as I have, 25 years. So I send those to him. And Sasha Rivkin, who you probably know in California and Beverly Hills, that's his whole practice. Sasha's whole practice is just injecting noses. So there are people who
I didn't know that.
Yes. Yeah. Do you know Sasha?
I don't know him, no.
Okay. Yeah, he's a cosmetic surgeon, has a very, very big practice. He would be a good one to interview on your program.
Oh, okay.
He's very articulate, and again, he loves doing noses, but like me, he's got the whole setup ready to dissolve something if in an emergency kit at hand. So
I don't know. See, to me, I've had experienced dermatologists say, "Oh, that's no problem." I've had a few people who've had necrosis of the forehead from injecting the nose. No problem. And I'm saying to myself, "What? Are you kidding?" I mean, if I have one of those complications, I'd be freaked out.
exactly.
And I think when I look at the literature and I read about the statistics of people going blind. I mean, of course, people coming in never dream that they're going to potentially go blind from injection, with something as innocuous as a filler, or what they think is innocuous as a filler. I reel back, and I kind of baited you in a little bit by asking me this question, because I'm opposed to it. I think that a lot of the serious cases, particularly in Asia, that have been reported, and I think, by the way, these cases are rare, but I think widely underreported because of the seriousness of the problem, the legal litigious nature of the complications. I think so many of these serious complications have obviously been underreported. I think that it's just not worth it. Not worth the risk of someone going blind from doing a nasal augmentation with an injectable. And I have done it once or twice, and I saw a little blanch, and then it went away, and then I said, forget it. That was a friend of mine, and I said, I'm never doing this again. I don't want any part of this, because I just think it's just too risky. And it kind of brings me to another question. And in this paper that you co-authored with some other prominent dermatologists primarily, and an oculoplastic surgeon, I believe, was on the panel.
Yeah. And a general plastic surgeon, and facial plastic surgeon. Jackie Yee was our
other specialist, right? Okay, yeah. We'll throw them all in there.
Yeah.
But now, I think that any needle, I've been an extremely strong proponent of using cannulas, particularly around the periorbital area, certainly anything, almost anywhere I use cannulas, except with some exception around the lip where I can't get the precision I want with a cannula. I think that it's a safer approach. Now, what baffles me, and you can make, I'm not asking you to answer as a industry representative. Why are the manufacturers putting only needles in their packaging of their injectables? When you get a package, you get a needle, and they should be putting cannulas in there. If they save one person's vision, it's worth the investment and the additional expense that everybody has to incur. I don't understand why they haven't done that. And I don't know if you can answer that. I know you're not the representative.
I can answer that, as a matter of fact,
You
because
can.
I've done many of the clinical trials. The first clinical trial I did was Roloxin, which is now Dysport. So that's how long ago I've been doing clinical trials. It's been out forever. And I did their original trials for Restylane and Perlane. And, when Restylane Lift was then Perlane. And it's because of registration trials. All the registration trials in the past have always been done with needles. There is one company, which is Teoxane, right? Which is the Revance products that they bring them in from Switzerland. Geneva is where the manufacturing plant is. And they just came out with the needle and cannula approval. So things are going to be co-packaged with a cannula. And so a lot of these companies are starting to see the need for that, the safety aspect, the decreased bruising risk. And they are they will start co-packaging. So I can guarantee you that RHA4, that was the product that we did the trial, where we did, half face with a needle, half with a cannula, is going to be co-packaged with a cannula.
That's progress. That's progress.
It is. So it's all based on registration trials. That's the answer to your question.
Yeah. And that brings me to another question, because like when Sculptra came out, and I went to a meeting at Sculptra, which is PLLA, and it's used for
and facial rejuvenation.
Facial rejuvenation, but I use it in specific ways to fill out the lateral face primarily.
I love that.
But when they originally came out, they said, well, you should mix this Sculptra product, which is not a hyaluronic acid gel, by the way, for the audience. It's little particles that get dissolved in sterile water and injected into the face. And I used exactly the formula that the manufacturer recommended.
And that was not
and they even sent a specialist out to quote teach me how to inject.
Yeah.
Okay, so I follow the formula to the letter, and I ended up with nodules which were highly undesirable. And so sometimes since then, of course, I personally went and modified that by diluting this material, and then I don't get these side effects anymore.
And now they came out with a study. They came out with the approval for an 8 cc's instead of 4 cc's. So now it's 8 cc's dilution, because they realized there were so many people like you getting nodules that could not be dissolved, and an immediate reconstitution. So now we're reconstituting immediately with that sterile water and injecting, and it's flowing beautifully. And by the way, when I do the Piriform with Sculptra, I always use a cannula. Always use a cannula for either the mid-face or the Piriform with Sculptra. I'll sometimes use the 1.5 inch hypodermic needle, a 27 gauge, for lateral face or other areas, but even a cannula there works great.
No, I use a cannula in those cases, but I'm just reiterating that sometimes the manufacturer, they're wed to certain things that they do for the FDA trials, and they can't even come out and tell you, quote, the right way to do it, and it compromises the surgeons to some extent, or the dermatologists, excuse me, to to deviate from their original.
Sorry.
Okay, it's okay. It's okay. So yeah, so they can't deviate from their original, recommendations. So anyway, I'm just reiterating the idea that cannulas to me are essential to avoid some serious complications and even minor complications like bruising and so forth.
So the one thing I would like to say about cannula versus needle is that I love all our tools. I love all our products. I love all our tools. I use every company's product. I'm not wed to Allergan or Galderma or Revance or MERS. But when it comes to being able to get projection of the lateral cheek, putting it on the bone and putting like, just bolus small 0.1 cc's to really get that nice angularity, I love a needle. To get projection in the chin, I love a needle. To get on the periosteum in the temple region, if I'm going to go periosteal, I will use a needle. If I'm going to go interfascial or subdermal, I'm going to use a cannula. So I think to myself, where do those vessels live in somebody's face, and make sure that I'm not using a needle where the vessel is, or where it comes out of the ostia or whatever. So I think that's very, very important. But like you, I love cannulas in a lot of different areas. If I'm medial to the pupil, I'm never going to have a needle ever in my hand. I'm always going to have a cannula. And to prevent bruising, I'm going to have a cannula. If I'm treating like a sweeping area, like with sculpture, the lateral face, like you mentioned, oftentimes that'll be cannula. So.
I have a question regarding, there was a recommendation to use fine needles in the glabella area. And I don't know if you recall that from that paper, but I said to myself, I think it's a little risky to use needles in this particular area here. I don't like to inject anything in here other than Botox or Botox cousins, but I'm a little concerned about any injections in here, and even on the forehead, I'm a little concerned about injections in this vicinity too with horizontal lines. But you enlighten me, please.
So yeah, I'll enlighten you a little bit about my technique anyway, or what I think. First of all, there are lots of people who would never inject the glabellar creases. And I try at all lengths to never inject the glabellar lines, because it is like the second highest risk location. We talked about Katie Belzney's article. But I also understand that the supraorbital and supratrochlear vessels come out of an ostia or an opening in basically the skull. And they're deep here. And then at about 1.5 centimeters, they go to support the blood supply to the forehead, but they're not superficial, typically in the glabellar area in those etched lines. So if in fact I'm going to do it, and I try to talk my patients out of it, I actually tell them that we're not going to do this until you have been using Botox for at least like a year. Because if you actually do Botox for a year and you do some laser resurfacing over it, you won't need the filler. And I do consent my patients in that area as the second highest risk location for blindness. That being said, like I told you, I don't ever inject noses. I do sometimes inject the glabellar lines, very rarely, and after talking to the patient about the risks. And if I'm injecting that area, I want to see the product coming out of the pores. I want to be that superficial. If my needle dives below the dermis, I'm in no man's land. I'm in a bad place because I know where the anatomy is there, and it isn't typically very superficial here. It's coming out deep, right in that little, you can feel that, that ostia right here.
Right,
And
the notch
so
right there,
the
right,
notch,
sure.
exactly.
Mhm,
Yep.
mhm.
So,
Uh,
so as long as you're getting backflow your product, you're very superficial, you're using very low pressure, you're using very small amounts, I will do it, but I never like doing it. I always
okay.
try and get them to do long-term Botox, and I show them a before and after picture of one of my staff members who had really deep lines. And then at about 2 years after she'd been getting her routine Botox, her lines were completely gone. And I have a really good before and after of that in my show that I bring to patients. And I said, look, this is the less risky alternative. This is what I'm recommending. But if you know, if you have your heart set on me putting a little filler there and you understand that is a risk of blindness, I actually do it. So
Yeah.
maybe
I
shame
can't
on
believe,
me, right?
but I can't believe people say, "Oh yeah, okay, I'll take the risk if I go to the."
Seriously, I don't have
It's
many.
like saying I'm going to go. I could die from this, you know.
Yeah, I have maybe 5 that I actually end up injecting their glabellar
Oh,
out of
oh,
thousands.
oh, okay, okay, I get it. There was a study done by first initials T. Pavicic, uh,
Oh,
Pavic,
Tatiana Pavicek. Yeah, Tatiana.
Pavicek,
Yeah,
right,
she's, yeah,
Tatiana,
yeah.
and she looked at different cannulas and needles. Uh, I read that study and I said to myself, there's a little problem here, and I want your input on this.
Okay.
Her study was basically to show that that if I can summarize it, is that the cannulas, if you use a 25 gauge cannula or less,
Or like a
meaning
needle. That's what she
or
said.
larger, actually 25, what's
You
called
needed, she
25
said to
gauge,
use a
or
25
less,
gauge
meaning the number gets less, but the size of the cannula gets bigger.
bigger.
Uh, it's relatively safe to decrease or what we call mitigate the chances of getting complications, but needles have a higher incidence of potential side effects compared to cannulas again. And uh, the only problem I have with the study, and I think it's a study that we should talk about because different manufacturers make cannulas in different ways. And I have looked at this in particular, like if you look at TSK cannulas, they have cannulas that are pointy, that actually could penetrate a vessel. And I've told them, I said, this this is exactly the opposite of what cannula is supposed to do. They actually have a pointy, sharp tip. So I think they need to have a standardized study using standardized cannulas. You just can't throw all cannulas into the mix and come up with an answer. You need to know exactly what cannula company you're using and what the kind of the anatomy of the cannula looks like,
Yeah.
because some of those cannulas are very pointy, and I think if you go to a 27 gauge or 30 gauge cannula by TSK, that's equivalent to a large bore needle almost.
Yeah.
So I think that there's flaws in that study that I see that were done. I think the conclusion that cannulas are safer was correct, but I'm not sure that the study really looked at the manufacturers, the difference between manufacturers. I think that's an important one because people think they're not all made the same. They're not all created the same. So, for instance, I use 27 gauge cannulas. I've never had, thank God, a serious complication from using it. So, I don't even know of a study showing people who actually have had embolization from using cannulas. Are you aware of any study where a cannula cause a complication?
Um, yes. Well, I think of one of it wasn't written up, but a person who was using a cannula who actually cannulated a vessel and then caused a problem with an intravascular event with a cannula. So I think that
wow.
it's certainly possible. I think your point with Tatiana's paper is well taken. I haven't read that paper in a while, but I think her main point was that, you want to use larger bore cannulas because, if you've ever injected somebody's hands with a cannula, you can see those vessels very well just move out of the way. You never go through a vessel on the hand with a cannula. The vessels are really mobile and they just move out of the way.
Right.
And so it's much harder to get into a vessel with a large bore cannula. And you're absolutely right about smaller. I remember when I was using I think it was a 29 or 30 gauge cannula, and it might have been TSK, and it was sharp. I couldn't tell if it was a cannula or a needle. And then after Tatiana's article came out, I'm like, okay, we're getting rid of all of the cannulas that are 27 or higher, 27, 29, 30, they're going in the garbage. And we are only using 25 gauge or 22 gauge cannulas. And that's all I use right now, 22 or 25 gauges. So
Okay.
you're really right about that. But I do think we don't want to get a false sense of security in that I do know, as a matter of fact, from a direct communication with a friend who was able to get into a vessel with a cannula and have
Wow.
deleterious effects.
I'm just wondering where they injected, and was it around the eye, or was it on the nose, or on the lower face? I mean, I don't know. Maybe it's just the way I just feel comfortable doing it. It was certainly I've never had a problem, but maybe I'm lucky.
Right. And also I think it depends on, like, when you're using a cannula, make sure that you're perpendicular to the vessels and not parallel, so you're not going to cannulate with your cannula like an IV.
Yeah. Yeah.
So that's important.
Well, it's sometimes it's hard because some people in my specialty, I fill these tear trough areas frequently, and if you really look at we look at the big vessels like the angular artery or the nasal dorsal vessels,
right?
but there's a plethora of vessels that are all over the place there, and if you're in the right plane, which I think is actually in the deep plane.
Yes, I agree.
And I think the chances of getting cannulating a vessel is relatively low. I
But you're
also
also
do. I have a
you
little different technique here. I'm going to share with you. Give me
okay.
your feedback on it.
Okay.
So prior to injecting this area, I actually pre-inject with lidocaine with epinephrine, and I do that for two reasons. One is it makes the patient more comfortable. And the second thing, it causes vasoconstriction. So the vessel diameter, if there is a vessel there, an artery vessel, it's going to contract.
Right.
And then I inject. Then I use my little needle that they supply in the packaging of hyaluronic acid gels, and I create my little track, and then I use a cannula following that. So it decreases the chances of a hematoma markedly, and it makes it more comfortable. And that's my technique. What's your take on that?
So it's a good technique. My one thing, it's not the technique I use, okay, but the only reason I don't use it is because, and I do use a cannula, like I mentioned, if I'm on the palpebral malar groove, I will actually put droplets of filler with a needle. But like I mentioned, anything when I'm going to be medial to the pupil, I'm going to be with a cannula. And I also agree that you need to be, periosteal or pre-periosteal, right on the bone, because there's all you have there is bone, muscle, and skin. So there's not a lot of other tissues in that tear trough area. The reason I don't use lidocaine in advance with epi is, and again, your thought process of getting the vasoconstriction is a good one, but you also get blanching. Epinephrine blanches the tissue. And if, God forbid, we get into a vessel, I would want to be able to, like, I have gotten into vessels before and immediately that blanch, and then okay, you're in the wrong place, take it, take your needle out, see if that skin pinks up and make sure it does, and that type of thing. So it's just the visual for me would be a little bit disturbing to me.
So you don't have a emergency way of identifying if you've gotten into the vessel.
Right.
You're taking away some of the visual cues.
It'd be harder to see that flash of when the blood's not going away. So it'd be harder to see that blanching or that whitening that we look for in getting in a vessel. But like you, if you're using that 25 gauge needle, 25 gauge cannula there, and you're worried about very, very small vessels, you're not likely, like you've experienced, to cannulate one of them. Big cannula, small vessels, not going to happen. So your odds are you're putting yourself in a good position with just that technique. But forget even just the idea of numbing the area with lidocaine with epinephrine, which I don't find cannulas to be very painful for my patients. Honestly, they don't really complain.
Yeah. I'm going to switch up the conversation slightly. What do you think about microneedling to rejuvenate the skin, or lasers following the use of fillers on the face? How do you modify your approach? Do you do the microneedling first before you do use facial injectables? What do you do?
You're talking to a very risk-averse person. So
Okay.
yeah, I am. I just am. And my practice is only, is 100% cosmetic, fee for service. I'm doing injectables all day, every day. I have PAs doing my laser treatments, and I do some laser treatments. And my estheticians are doing the microneedling and the RF microneedling. But in my practice, really, most of my injectable patients are getting Botox and filler at the same time. And I kind of have a rule of thumb that if I'm going to be doing Botox, I don't want your face swelling for at least a week afterwards. So I don't recommend to my patients that they have a Fraxel done on the same day as, having filler or Botox or a neuromodulator. Now, if they're doing like light resurfacing, like, clear and brilliant, or maybe radiofrequency microneedling that has no swelling or no pinpoint bleeding, then I have more of a comfort zone for that. But in general, my practice knows to kind of separate those time-wise. There are a lot of physicians who do multiple treatments at the same time. Sabrina Fabi's one. I've heard her talk a lot about, just doing everything at one time. But I really, if you've ever had a patient have a ptosis after doing Botox injection and a resurfacing procedure within a period of a few days, you'll never do it again. I had a patient who flew from California to see me. She wanted to do Botox. She wanted to get her Fraxel done. We did it in the same week. Lo and behold, a week later, she sends me a photo. She's got lid ptosis. I'm like, okay, that was before Upanique was available. We did have iopidine and phenylephrine, so I called that in for her. But it's never fun. It's always better to be safe than sorry.
Yeah. Well, I agree with you that we shouldn't do. Personally, this is my personal. I don't ever consider doing those two things simultaneously. But what kind of effect do you think microneedling has on the filler? Say I have filler this week, and next week you do microneedling on me with radiofrequency. Do you think that heat generated by radiofrequency is going to modify the filler in any way?
I have a lot of patients who've had filler and they do the RF microneedling or, regular mechanical microneedling, and I've never seen dissolution of the filler. Now, I have seen migration of filler when procedures are done that produce quite a bit of facial swelling. So like, again, if somebody has a Fraxel or a Halo, and they might have had filler, more recently, and even honestly, you're an oculoplastic surgeon. You understand that old filler around the eyes can migrate. 5 years
Mhm.
later, it can migrate.
Yeah, yeah.
Yeah, so, I don't find the dissolution or the dissolving of the products to be an issue because I've never seen it and I've really never read any reports about that. But I do think that potentially migration could occur.
You think the needles go down deep enough to interface with any of the
So the
fillers?
needles are 1.5 to 3 millimeters deep,
Okay, so it's not
So,
getting deep enough.
yeah, I mean, most
I
filler,
mean, you're doing it subdermally, really, the injection, but
yeah,
still,
that's what I was gonna say. We all think that and you probably remember that study out of Michigan a long time ago, finding that when, physicians think that they're putting their filler intradermally, but then there's punch biopsies done and all of the filler, except for maybe 2 patients, it was all subdermal or,
mhm,
in the fat or wherever. So, we're not going that deep with our microneedling to get into the fat.
okay, okay. I just thought there might be a kind of a, well, if you use CO, how about CO2 lasers? Do you think it penetrates deep enough?
The CO2, no, I
No.
don't. I think the CO2 is definitely a papillary dermal injury.
Okay, okay.
I mean, you shouldn't be going so deep with a CO2 or you're going to get scarring. So
Okay, I'm going to ask you the second big area. This is a long discussion. I'm sorry it's so long and tedious, but I got so many questions for you. If you have to go, let me know. I'm just sorry that I have to ask you all these questions.
sure.
So tell me what your approach is for your horizontal lines in your neck. Some people have these deep horizontal lines in their neck, and I'd like to hear your take on your approach to that.
Yeah, so that's kind of, people call it tech neck, a lot of the younger generation,
Uh,
because everybody is looking at their phone all the time.
oh,
And so
neck
that
neck.
horizontal,
Okay.
and a lot of times I see the horizontal necklace lines in, younger people. My approach is really twofold. And let me preface it by I am doing a clinical trial for Allergan right now, treating the neck area with Volite. So, that's basically an ongoing clinical trial as
I
a
see.
skin booster. So trying to get the quality of the skin. We know the thinnest skin in the body is periocular and the neck skin. So if we can thicken that skin, then we're going to have better elasticity. We're less likely to have that folding effect causing those deeper wrinkles. So with that being said, we don't have Volite at this point. We don't have that in the US. They have it in Canada, but not here. And so what I do for tech neck is I use a very, very light filler. The one that I particularly like is called Redensity, and we will be talking about the RHA products, and Redensity is one of them. Before we had Redensity, which was about a year ago, we had, I was using Bellatero. So, so I find Redensity and Bellatero to be both a very, very, very light kind of watery fillers, not thick. They don't have a lot of, substance to them. So I want something like that because that skin is so thin. And I will basically either backflow a BD needle, so I have more precision with less pressure, and just serial puncture the horizontal necklace lines, just kind of really superficial, trying to be as immediate subdermal as possible as a filler. But also I find that those deeper lines, they're kind of tethered down a little bit. So before I actually do that, I like to take a cannula and subsize
Oh,
the
okay.
area. So I'll take my cannula and I'll make one little, trocar opening, and I'll take that 25 gauge or 22 gauge, and I'll just kind of fan around to try and lift that skin. Then I'll go back. I'll take my BD needles that have a very thin, very watery product, and I'll serial puncture
Oh,
immediately subdermal. Then I'll take a Q-tip and I'll use the wooden part of the Q-tip because it seems to spread the material out better. And when they walk out, you have to be 100% sure that they don't have little mosquito bites. They don't have any elevated papules, or those are unlikely to go away later. So you really have to be, I think, it subdermal, immediately subdermal, not intradermal. And that's sort of what the company Allergan is going for, is an intradermal or immediately subdermal approval for the Volite.
I see. Because I've attempted to inject those, and what happens is when I inject in the line, the material kind of spreads on each side of the line. It doesn't kind of lift the line up. As you said, you have to subcision the line, meaning you have to actually go in and kind of lice the line and make it elevate
less
elevate
bound
these
down.
horizontal lines. Yeah.
You want
Yeah.
it less bound down so your product can get right into those lines.
Yeah,
So
well, surgically we do that when we do a neck lift. We go down and we undermine all those lines so that we kind of eliminate some of that. But they can reform, and
but the other
that's
thing I must tell you that I do, and that's a good point, because you just said it could reform. I tell my patients it's a series of 3 sessions spaced by 1 month apart, so that you're putting small aliquots in there. I only use 1 syringe for no matter how many lines they have across their neck, I'm only using 1 syringe. And then you'll see some okay improvement, maybe 30 to 40%, but you're bringing them back a month later and you're doing it again. And then you're bringing them back a month later and doing it a 3rd time. And once you've done it 3 times, those lines are looking, I would say 80% better. Not gone, but 80% better.
That's impressive. That's impressive. Really good.
So try that.
I'm going to try it. That's why I'm asking the question.
Yeah.
And my final area of interest to pick your brain is on the RHA family. How does this group of fillers fit in the paradigm of other fillers that you use? I'm not totally sure. Even looking at the pre and post-op pictures of patients, I understand it's more dynamic in terms of making it look more natural. I think other companies have attempted to do the same, refine, define, all that stuff, with different companies coming up with dynamic fillers that are more stretchable. By the way, the RHA family is Teoxane is a manufacturer, and
distributors.
If I understand correctly, they're not cross-linked, correct? They're not cross-linked fillers.
So basically, it's called preserved network technology. So actually, the way it's manufactured is slightly different. I was in their manufacturing plant. I took my daughter skiing in Zermatt, Switzerland this past Christmas time. And so on the way back, I stopped at their plant in Geneva. So I actually got to see the manufacturing of the RHA products. And the best description that the company uses is sous vide, like the cooking. So it's very, very slow, using very low heat, gradual, so that you don't get a lot of breakdown of the non-covalent bonds. So the bonds, which are the more natural non-covalent bonds, are more maintained. So that product doesn't need to have this stringent BDDE. It has some BDDE.
What is that? What is that?
Huh? BDDE? BDDE is how all fillers are bound together. Oh. So, natural hyaluronic acid in the body is kind of free floating, and it comes and goes, and, it doesn't stick around. But all of the hyaluronic acid fillers, the reason why the durability of them is like a year, 15 months, for Voluma 2 years FDA approval, is how the hyaluronic acid strands are bound together. And so the most common way of bonding is called BDDE. Which is a covalent bonding. Okay. So the difference with the preserved network technology is longer strands of hyaluronic acid, which are more like our natin or natural hyaluronic acid, less strong bonding with BDDE, although there is some covalent and non-covalent bonding. And so that is the whole story behind why this product is more integrative into the tissue, stretchability, it moves with the movement of our dynamic faces. And that was sort of their, like you said, Express technology kind of came out with that whole paradigm of, you know, a picture isn't frozen. We're always using our faces. So we need something that's going to move with us. And then Revance took it to the next level with natural looking at rest, but dynamic in motion kind of filler. So that's basically was their buzz. And I do think, because I've been in practice 25 years, I do think that the products become integrative with your own soft tissue. And so like if you get filler here and you're using the Revance products, you don't feel the lumps or the bumps. It tends to again become part of you much. Yeah, it becomes part of you much.
Is that a good thing? Could it be more immunogenic? Meaning, could it cause an immune response because there are, you know what I'm saying?
It would be less immunogenic because it's got more of the natural innate bonding than some of like, you know, and it has the longer hyaluronic acid strands as opposed to the shorter ones. Vicross technology has more of the short HA, and Vicross has been touted to give a little bit more of the immunogenicity that you're talking about, hypersensitivity reactions. So I do think that I really like the products. I say that, and I hardly use any RHA4. Why? Because why don't I use RHA4? Because I had one bad hypersensitivity reaction to RHA4 that was very hard to get rid of. It took 3 months of dissolving it with 7 vials of hyaluronidase. So well, that's
a good question. Are these RHA products more difficult to dissolve because they're now more integrated into the tissues?
So I think Voluma is hard to get rid of too. And Volux is really hard to get rid of. I had a patient with a reaction to Volux, and that took like months and months. So I think a lot of these products that are placed, you know, that are thicker products like Voluma, Volux, RHA4 rather than 2, they're more, like I said, thicker. They have a higher G prime, stiffer, they stay around longer. I think they are harder to dissolve. I don't believe that there is a company out there that has a product that is not possibly immunogenic. When the Revance products first came out, they were like, well, these products, we've never seen it. And in the clinical trial of over 300 patients, they didn't have an incidence of that, which is great. But, you know, after a clinical trial is over 300 patients, we're injecting thousands of patients. It's going to happen. So no company can tell me that their product is immune from having a potential problem. We know that hypersensitivity reactions are multifactorial. It's not just the product, it's the person. And maybe not just the person or the product, but it could be the injector and how they prepare the skin. Like there's just so many things that go into that it's not straightforward. That being said, I really like Redensity for those fine etched lines. And I really like RHA2 for sort of that oral commissure support. And I like RHA3 for the nasolabial folds. I like the RHA products in mobile areas. The areas that are under a lot of stretch and strain and, you know, smiling and talking and kissing and all those things. I really like them there. Like I mentioned, I don't use hardly any RHA4. So
do you really see if you see side to side, do you really think there's a huge difference in the way the patient looks after? Can you tell an RHA patient from, say, a Juvederm or a Restylane patient?
Well, I think that the Juvederm and Restylane has more hydrophilicity. Like I think that they swell a little bit more and it's a little firmer for longer. I think that eventually all those products can do about the same. But remember one other thing about the RHA products that's a real advantage, and that is that they have a 15-month approval. The FDA approved them for 15 months, whereas Restylane, Refine, Define, the FDA approval is 12 months. So when I talk to my patients about it, I say to them, well, look, I can tell you what I like, but I can also tell you what that company's approval is. So then you can decide, like Voluma is a 2-year approval. When you tell your patients that there's something that's going to last 2 years, they want that. They don't want to be coming in all the time. They want something that's longer lasting. So if they're, you know, if my choice is like an RHA2 or a Refine, and I know that the, you know, RHA2 has a 15-month approval, people are going to gravitate
some of this
towards
stuff
that.
is hype. Some of this
It
stuff is
is.
hype.
A lot of
You
it
know,
is.
I
So
mean,
it's,
I used to hear that Bellotero never caused a Tyndall effect, a blue
that's
tinge
untrue.
to the eyelid, and
Untrue.
people ran to, I saw it. So my point is, some of it is salesmanship. You know,
So
I'm not so sure, huh? I'm not
some
so
of it
sure
is
that some of the,
salesmanship.
you know, approval lengths really match up to the reality. You know, sometimes it's much longer, actually. You know, there are people you inject Voluma on, and it may last 5 years. I mean, you know,
And
so,
Restylane under the eyes, for sure, it
yeah,
lasts 5 years.
yeah.
So
So, you know,
you're right.
I don't know if I believe all that, but
So
I
it's a
understand you.
talking point. It could be a talking point, though. So,
Yeah,
I mean,
yeah.
if you like the
But
product,
we're talking their points is my point.
right, right. But if you like the product and the patient's like, okay, first of all, they'll ask you what you like, and you have to tell them what you like.
Yeah.
And then whatever that is, if you want to sort of lead them a little bit towards that particular product, that is one way to say, okay, well, in the trials, and trials are a fluky thing because, you know, trials, you use more product than you would in real life. Trials, you're allowed a touch up at 2 to 4 weeks, and then this clock starts ticking thereafter. So trials are artificial. And I do tell my patients that. I'm like, the way trials are run is artificial. But that being said, these companies spend millions of dollars to get their products approved. And so if they get an approval of a longer duration, that's just a little extra, star on their cap, right? I mean, that's like, it's something you can go with.
It's a marketing thing.
It's a marketing thing. But all this stuff, a lot of it's marketing, right?
Of course. Well, listen, I'm not going to take up any more of your time. I want to let the audience know that if you have any questions regarding fillers, you can certainly contact Dr. Susan Ellen Cox in Chapel Hill, North Carolina. And this has been a great pleasure to speak to you. I'm going to plug my name, Dr. Kopelman, Joel Kopelman in Manhattan. And if any questions you have, please send them to us and below, and we'll forward them either to Dr. Cox directly or to me. And I appreciate your time. It's been really a great pleasure for me to speak to you, because I consider you the real expert in these areas, and it's been enlightening, and I really thank you for your time. I really do.
Thank you. It's been an honor, and I hope we do it again.